Hello again. Welcome to our next installment in our anatomy physiology course here at Ivy Tech. This section is on the integumentary system, which basically means the skin. Now, the skin is comprised of a bunch of different types of tissues, has different layers, and has different functions. So we're going to be focusing on some of the functions of these things, as well as looking at a little bit of pathophysiology at the very end, where when we lose skin function, what some of the problems might be. As always, you can ask questions, text them to me, or email them, or save them for class. This lecture, this video is meant to be a supplement to our regular class lecture. So when you're looking at a slide like this, very complicated, lots going on. The key isn't try to stay at 10,000 feet, if you will. Try to Monet this from far away. The key is to understand that this is like a road map. All right, and you can break this stuff down conceptually. Like, let's start over here on the left. The skin is composed of basically three basic layers. You have the epidermis, which is involved in, you have a sublayer of proliferating cells that then increasingly fill with a protein called keratin, and they begin dying and they lose their nuclei, so that we get this sort of translucent layer at the very top called the stratum corneum. So you have this epidermis, you have dermis, which has got more of the blood vessels and more connective tissue, a lot of the glands, et cetera, et cetera. And then you have the hypodermis, which is usually adipose tissue, and that can vary depending on the region of the body, as well as whether you are genetically male or female, and so forth. You do have some sensory organs down in that adipose tissue. Even hair follicles can contribute down there, but mostly it's fat cells, a few glands, and some blood vessels. So again, we can break it down in very fine detail, but this is the main thrust right here. If you can start here, then the other things will sort of fall into line later on, rather than trying to swallow the pizza all at once. There are different kinds of skin out there, and there may be different interpretations about what we mean by types of skin that the body has, and you can get lost in the Google search. So the key here is to understand that we're talking about more of an anatomical and physiological difference, rather than, shall we say, cosmetological along those lines. So the two types that we have, and again, consult your book. You can always double check me on this. I'm going shooting from the hip a little bit here, but this is how I understand it. Is that you have hairy skin, and this generally is a little oilier because you have more glands, and you certainly have the hairs and so forth. And then you have a type called glabrous skin, which this is actually an example of this. You don't see a lot of glands in there, certainly no hairs. It's hairless skin versus hairy skin. So hairy versus glabrous. And here are the main layers. We'll talk about that in a subsequent slide. Again, you can get lost in the cosmetological condition, because obviously skin does vary around in terms of how much exposure to light it gets, whether or not the skin is sensitive to signaling from within the body. Lots of blood vessels, not very many blood vessels, lots of nerve endings, not very many nerve endings. And so you'll see this type of thing: the dry, normal, oily, combinations, et cetera, et cetera. This is not irrelevant, but in our case, it's too much, and it's too much on the cosmetological side. So we're going to stick with these two here. And again, if you see something different in your book, let me know, and I'll make sure I update my slide. Unlike some of the other jokes, I kind of like this one, where we have a layer of cells that are still alive, and they're talking to each other and say, do you find it odd that there's a bunch of corpses sitting on top of us? That's true, because the cells on the outermost layer, the outermost layer, the stratum corneum, are dead. And not only dead, but they lack nuclei. Let's call it more of an uncomfortable glimpse into our future, because that's what's happening. As we go from this base layer these cells are dividing, and then as they get further up, they're differentiating. These are more generic cells. They lack the differentiation factors and specifications. But as we get further and further up, the more we go, the more differentiated the cells become, and the more the cells begin to shift from a living cell to a non-living cell. They lose their nuclei, they crystallize with keratin, and thus become the outermost layer. So here are the 5 major layers, and you don't always find all 5 layers in your microscope slides, and we'll show you what I mean here in just a second. What you do always find is a stratum corneum, and this is a varying thickness layer of dead cells that have basically accumulated keratin to the degree that it's basically crystallized inside those cells. Keratin is an intermediate filament protein. You find it in hairs, okay? You find it in your fingernails, and there's just different densities. And the real irony of people that kill rhinoceroses for their horns for aphrodisiac reasons is that horn is just made up of keratin. It's the same as if you'd gotten it from their hoof or some other, or the hairs in their tail or something. It's really rather silly. So they're flattened, they're non-nucleated, and they're cornified. On some areas of the body, primarily lips, palms, and soles, okay, you have this what's called a stratum lucidum, which is where the cells have lost their nuclei, but they haven't completely developed the keratin level. And so if you look on a microscope slide, you might see this layer if you happen to have the right slice from the right place in the body. Then you have a granulosum. This is where the cells are beginning to lose their nuclei. The nuclei, this is the term would be called apoptosis, but this isn't really complete apoptosis. This is more of what we would call a differentiation level apoptosis, because these dead cells have a very distinct function. In apoptosis, the cells literally break up into small blebs and are reabsorbed, but that's not happening here. In any case, but the nucleus does do that sort of thing. The nucleus condenses and begins to shrivel and begins to be absorbed by the cell for caloric reasons to be converted into keratin. Below that, you have the spinosum, and the reason they call it the spinosum is because it tends to kind of form these spines. It's not shown here very well. They're less differentiated. They are actively dividing, but not as fast as the very bottom layer. They are still dividing, though, and as they divide, they're beginning to differentiate. They're beginning to start expressing genes that will then lead them down the path to forming these corneated cells. The really active layer, and you could call these cells down here stem cells. Stem cells are the least differentiated and the most active in terms of mitosis. This is why you're seeing the different nuclei here, different areas of the cell cycle. And these are, they say a single layer. It's generally a single layer. They're cuboidal cells, and they are actively producing new cells. This is also where you generally find what we call melanocytes. These are skin cells that are expressing melanin. Melanin protein registers as a darker color. Depending on how much melanin is present, the darker the color. Even very fair-skinned people, if assuming they're not too sun sensitive, if they get a little bit of sun, that inflammatory response will induce pigment development, and thus that's what skin tanning is. All right. So you have the melanocytes, you have actively dividing cells. This is the stratum basal, and this is where you would find the basement membrane, though I would argue that there are probably some extracellular matrix in between some of these other layers. But the main basal lamina in this epithelium is right here underneath that stratum basal. So speaking of melanocytes, which we find in the stratum basal, melanocytes are the primary driver of skin color, but there are other pigments, and this is why we can literally have shades spanning the spectrum from a bluish or a reddish tint to a more orangey, bronzy color to a much more dark, very dark pigmentation. There are 3 pigments. Now, most people are familiar with melanin, all right, from the melanocytes. But here are the three pigments which can affect, and you can see there's a wide variety of shades. You can get a reddish color, like my skin is a bit ruddy. That's the phrase, and to all shades in between. So hemoglobin can play a role depending on how much hemoglobin is present in the blood. You can, if the hemoglobin is oxygenated or not. So skin color isn't static. It can change and can literally change moment to moment. All right. It can literally change moment to moment depending on how well oxygenated the hemoglobin is and how much hemoglobin is present in the areas of the skin which are translucent enough to convey skin color. So if you have lots and lots of blood vessels and that blood is highly oxygenated, you'll have a more reddish color, because hemoglobin, when it is fully oxygenated, is a bright red color. All right. So it can depend on age. It can depend on, injury to the skin, long-term injury, short-term injury, or different types of disease states. Okay. So we can see vast changes in skin color just based on hemoglobin. Another one that you might not have expected, now you see the word carrot in here because the carrot has a lot of beta carotene, and there are other molecules very similar to beta carotene called carotenoids, all right, or carotenoids if you want. And that starts to sound like keratin, the protein, which is spelled differently. But carotenoids have a reddish to orangish color. It can vary a little bit. If you see the fall colors in the leaves in the fall season, some of those colors, the reds and some of those other things, are carotenoids. All right. So, and we have those too. Depending on how many carrots you eat, if you eat a pile of carrots, the beta carotene will start accumulating in your skin. All right. So this could be, so your skin color could vary based on your dietary habits. All right. But carotenoids are generally sort of an orangish, light brown, yellowish kind of a color. And so they can also affect skin color. And then our most well-known melanin, usually a dark brown or a blackish color. And again, the combination of hemoglobin, carotenoids, and melanin give us the vast diversity of colors that we see worldwide and in our own country. Now, this skin color chart here is showing you the effect of hemoglobin versus the effect of melanin. You can see that the melanin ones don't look all that different. There may be it's hard to see. This is not the best quality image. Okay, it's not the highest resolution image. But you can see that as melanin rises, the impact on hemoglobin drops a little bit. Okay. So if you have low melanin and low hemoglobin, or if it's not very oxygenated, you'll have a more paler color to your skin, maybe even a slightly bluish tint, in some cases very, very pale. Or if you have a lot of hemoglobin, then you'll have a more reddish and so forth. And you can sort of see it in these first two or three, how hemoglobin plays a role as melanin increases. So along with basic skin pigmentation, we have some terms to talk about times when skin pigmentation sort of falls out of the standard ratio, if you will. Our first one is when you lose melanin. This is called albinism. It can be systemic, okay? It can be because of a genetic situation. It can also be regional and or local, all right? There are lots of conditions that will drive albinism. All right. But the primary characteristic is that the skin will be very, very white because you no longer have active melanocytes. Either the melanocytes are no longer expressing melanin or the melanocytes have died off, sometimes due to autoimmune situations. In folks that have what we call true albinism, that is to say, complete systemic albinism, because for whatever reason their melanin gene is turned off, their pupils will actually look pink. That's because everyone is black when it comes to what we call the pigmented epithelium of the retina. This is an epithelium that is behind the photoreceptor cells and is tasked in part with absorbing the light as it passes through those photoreceptors. And so since they lack the melanin, Instead, what you have is the blood vessels creating the primary color, and the light is reflecting off of those blood vessels and hemoglobin, and so you get pink. Oftentimes, people that have that significant true albinism do have some visual disorders because, again, that pigmented epithelium is now reflecting more light than it should. Erythema, this is an interesting one. This is where you get increased blood flow due to vasodilation. Okay, so there are capillaries in your blood, in your skin, and the capillaries in a given area, sometimes all the area, like if you're blushing, okay, if you're embarrassed and you start to get a red face, that's a form of erythema. All right. The most common kinds of erythema are due to ischemia, like if you've been sitting too long. If let's say you you lay your hand on your head on your hand. If you left it there long enough, like for half an hour or so, and you didn't move, if you took your hand off, at first it would look pale, and then you would see it get red from where your face, the skin in your face, has experienced ischemia. And so what happens is they send signals out to vasodilate. The skin's reddened. You can also induce erythema by injury. So if you flick yourself like I did in class the other day, that injury induces a mild inflammatory response, and vasodilation is part of that. If somebody's laying in bed too long, for instance, a bedridden patient, that's one of the reasons why we turn them in order to avoid the injury inflammation. But when we do turn them, you might notice that the skin that's been under the weight of the body will be red for a period of time. That's due to the fact that that skin hasn't had oxygen and glucose for a while, and it needs more to make up the deficit. So we get erythema. Cyanosis is sort of the opposite of erythema, though in cyanosis you may have plenty of blood flow, but you lack the oxygenated hemoglobin. In fact, you can actually measure how oxygenated the hemoglobin is by how red it is. That's what a pulse oximeter does. It basically has a red light in it, and it looks at the reflectivity of that red light. If there's not very much reflectivity, that means it's bluer, the hemoglobin's bluer, and so doesn't reflect the red light as well. So cyanosis is when you see a bluish tint to the skin, and that can be due to either lack of oxygenation, like if they haven't been breathing or choking and so forth. Then we have pallor. Now, pallor is different from cyanosis in that pallor is due to lack of perfusion. You got a vasoconstriction response. That can be due to being out in the cold a little bit, but it can also be due to cardiac insufficiency. And this is a color you don't ever want to see. All right, you got a patient that is standing still and they have a pallor to them, and you will know it when you see it. All right, they will have a color and you're like, oh my God. Okay, happened to me. I was working in a research lab, just happened to be next to a cardiac clinic. Walked out, saw this person, and my paramedic training just kicked in. There was no visiting the receptionist on this one. This was a true medical emergency. This patient was minutes away from going into complete cardiac failure. It was obvious. They were walking down the hall and they had this color and they were having trouble. We just went right by. We didn't even pretend that the receptionist existed. Took her right to the charge nurse, and because it was a true medical emergency. You can also see this pallor due to things like extreme fear, sympathetic response. Okay, one of the sympathetic responses, especially when somebody's really scared or stressed, is vasoconstriction in the outer skin, and you get a pallor. Raynaud's phenomenon is a type of autoimmune disorder. I saw Raynaud's personally when we were snorkeling. And I actually have a picture of it where underwater, it didn't manifest on the surface. When they were on the surface, they were just fine. But when you get underwater and the water's pushing on the hands a little bit, it really accentuated the difference in blood flow. And actually, you could see these patches of very, very white pallor due to the combination of the lack of blood flow with the increased water pressure. That's called Raynaud's phenomenon, and that's a localized pallor. Lastly, we get a form of thing called bronzing, which is similar to tanning. Okay. In fact, tanning does fall under this. All right. So if you have extra melanin forming, and this can be due to exposure to sunlight, or can be induced with certain types of drug responses, or if you're getting iron, perhaps copper deposition, this is a little bit unusual. But if you have too much iron and too much copper, it will begin to deposit in the skin, and it deposits as a bronzer color. Addison's is an adrenal insufficiency, and so Addison's will you can see this. You can see this typically in folks that are significantly obese. So if you see somebody who's significantly obese, and they're wearing shorts or something, look down at their legs. You will often see a hemochromatosis. You'll see a hyperpigmentation in their legs, often due to vascular insufficiency and deposition of iron and or copper. The last one here is jaundice, and jaundice is liver insufficiency. Liver is tasked with handling iron. And iron is generally kept under lock and key. It's way too reactive to be safe in the body. So the body keeps it locked up inside molecular cages, if you will. And once a red blood cell is slated for destruction, after about 3 or 4 months, it gets slated for destruction. The hemoglobin is metabolized into a compound called bilirubin. And bilirubin is nothing more than a molecular cage that contains iron in it. And bilirubin has a yellowish, greenish yellow tint to it. And if the liver is not handling the bilirubin properly, because most of your bilirubin is actually excreted fecally, that is to say, the liver passes it through the bile. That's why we call it bilirubin. It's bile color. And it goes out into the digestive tract and is pooped. Okay, that's bilirubin is what gives poop most of its color. All right. And so if you're not getting rid of it that way, it starts to build up in the skin, and that's where you get this yellowish color. Now, if you are a dark complected person, you can also spot jaundice in the sclera of the eyes, the whites of the eyes. It behaves just like skin, and then the eyes will take on a yellowish, golden yellow. Urine, the color of urine is also due to a little bit of bilirubin. It's not the major excretory route, but you do excrete bilirubin in the urine, and that's what gives it its yellow color. So moving on from the epidermis, which is shown in purple here, this is the epidermal layer along with the cornified layer there on top. We have what's called the dermis, and the dermis is a little more complicated than the epidermal layer. It houses capillaries and lymphatics. Lymphatics have a couple of different functions, and you should kind of get to know these things. Lymphatics are tasked with returning fluid that has moved out of the capillaries back into the bloodstream. And secondly, the lymphatics move that fluid through what are called lymph nodes, which are where immune cells are found, and they surveil that lymphatic fluid. The skin is near the external environment, and so it is subject to potential pathogens and or injury. And so those lymphatics, the fluid from the skin, is an important surveillance tool in order to prevent infection or invasion of pathogens. All right. And so we have capillaries, we have lymphatics, and we also have sensory neurons with their associated little differentiated things. Now, this papillary layer, the reason we call it a papillary layer is that it has these little cone-shaped projections. It's almost like a mountain range, if you will, in 3 dimensions, okay? These little ridges up are actually cones. And the reason you do that is so that you can circulate blood vessels and you can get neurons and stuff way up high in that epidermal layer without actually having to go into the dermal layer. Or epidermal layer, excuse me. There's a basal lamina running right along this interface. And so you can still get diffusion, you can still get sensory function without actually having to penetrate the epidermal layer by having these papillae. These papillae are cone-shaped structures. Below the papillary layer, we have what's called a reticular layer. Okay, it's reticulated. When you look at it under the microscope, it has a kind of a crosshatch pattern. Consists of connective tissue, very, very dense, very fibrous, very tough. All right. It's got a lot of elastin in it, a lot of collagen. It's irregular. That's because it varies depending on where it is in the body and what it's doing. Strength and flexibility allows for stretch. It also has good tensile strength, so you can't just tear your skin off of your body. If you have scurvy, you know what scurvy is? That's a chronic vitamin C or a significant vitamin C deficiency, usually chronic. What happens in scurvy is that your skin begins to get very, very loose and almost at risk of sort of sloughing off the tissues underneath it. That's because the collagen can't form properly. And that's due to the vitamin C. Vitamin C is really, really important for the appropriate collagen formation. And so back before vitamin C was able to be transported around the world, like say in the 1700s, 1600s, and so forth, when sailors were sailing around, they often didn't have access to vitamin C, and so scurvy was quite common in the maritime sailor populations. Reticular is also where you find the bases of the hair follicles, where you find the glandular stuff as well. So this is where the glands originate. Now they will penetrate up, like for instance, you can see these hairs penetrating up, and some of these glands will reach the surface or near the surface. Just another picture just to show you the different layers, okay? If you want to, the more you learn this, the better off you'll be, but you don't have to get crazy with this picture. Here's the epidermal layer. You can see the stratum corneum here. You can see the stratum basale. That's where your melanocytes are. Basal lamina is there. And again, you can see the dermal layer. Again, you don't see the two different dermal layers here. Okay, the reticular layer would be kind of lower down in this, okay, and the papillary layer would be up above. Okay, so these are the 3 skin sensory receptors that you'd like to be able to recognize in terms of their names, okay? You have Merkel's discs, and these are basically free nerve endings. They're one of the least differentiated free nerve endings. They don't have a cap, so they're least differentiated. And also, because they're the least differentiated, they will respond to the most different types of stimuli. Okay, these guys are often involved with pain sensing. So for instance, if you were to push your finger onto with your right index finger onto your left arm, you can push and it doesn't hurt all that much. You keep pushing and it starts hurting, now you're kicking in the Merkel's discs, because Merkel's are not particularly differentiated. They're not specialized to a given sensory mode. But what they will do is fire up when the sensory mode, whether it's heat or pressure or whatever it is, gets to a certain intensity. Okay, you can find them in the stratum basale, which means they're right near the very basal layer of the epidermis. All right. Then you have Meissner's corpuscles. These are actually quite differentiated. They're sensitive to tickle. Okay, they're sensitive to light touch. So if you stroke your skin very, very lightly, or the good place to do it, you have a lot of these, is in the back of your neck. Okay, sensitive to light touch. I found them in the dermal layers. All right. And then Pacinian corpuscles. These guys are the ones that are for vibration, deep pressure, et cetera, et cetera. Okay, so if you were pushing really hard with your index finger to the point where you're feeling pain, you're stimulating Pacinian corpuscles as well as Merkel's discs. Right? So it doesn't have to be hard, just some simple basic characteristics, where they're found, generally where they're found, and what their primary mode of sensitivity is. The main thing about this picture of the structure of the hair is that realistically, this is nothing more than a secretory gland. All it's doing is secreting a crystalline structure of keratin. Okay, so really, there's not a ton here that you really need to focus on. There is a muscle here that's called the erector pili muscle. That's your goosebump sort of thing. But other than that, it's really just the same story that you would see with any other gland, except instead of it being a liquid or a semi-solid of some kind, it's actually a solid shaft. So looking back on that previous slide would actually be, even though it is a hair gland and it's not categorized in the same situation, it would be most similar to this merocrine gland where you're releasing vesicles of contents. All right. So what you're doing in the hair shaft is you're releasing a vesicle and it crystallizes. There are other types of glands out here. So this is a vesicle type situation. This one here, what you have is you're sloughing off pieces of cells. So rather than having a vesicle that then that merges with the plasma membrane, the entire vesicle basically breaks off. Whatever is being secreted is created in the cytosol of these cells, and then the cell membrane pinches and releases off these portions of the plasma membrane. The third one is called a holocrine gland, and this one here, whole cells are released. In fact, a lot of the milk glands in animals, this is the way that it works, and that's why you have to homogenize milk. Is the fact that that whole cells are being sloughed rather than either parts of cells, or in this case here, the vesicles release and the membrane stays as a part of the original cell. So if we apply those general categories to the skin, so those glands can be, in the previous slide, can exist in lots of different places in the body. Now let's apply those three types sort of to the skin, if you will. So there are actually four subtypes here. We have the sebaceous glands, and these secrete oil onto the keratin crystal structure of the hair and help maintain pliancy and prevent fracturing and so forth. We call them split ends, if you know what I mean. The sweat glands that are called the eccrine sweat glands, these are the most common. This is a merocrine situation, again, vesicular. So you have these vesicles that are releasing the sweat into the tubule to be released. And then you have apocrine sweat glands. You find this mostly in areas that have hairy skin. And then the ceruminous glands. Now, cerumen means wax. So these ones are modified sweat glands, only they're releasing a much more viscous material, earwax, if you will. Since we're talking about skin, we should also talk a little bit about some of the basic pathophysiologies of skin. One of the big ones being skin cancer, which if you were just to look at cancer, period, and what organ the cancers arise, skin is far and away the most common place that we do get cancers. Thankfully, being external means that they're among the most treatable. So here are the three main types. You have a basal cell carcinoma, and again, it's coming from what they think are the cells in that basal layer of the epidermis. Again, it's hard to do all the diagnoses here, but at least we know where it's coming from. I think that's the most important thing. You have a squamous cell carcinoma. Now, this one is one like melanoma that seems to be sun related. So you start to get an unusual cell. Maybe it's red a little bit because it's inducing it's inducing angiogenesis, that is blood cell or blood vessel invasion. And so these ones are on the surface and they're often sun related. Again, scaly, irregular, et cetera, et cetera. Melanoma, yeah, the most dangerous type. Again, it's arising from that lowest layer, which means that it can potentially invade downward instead of upward. Melanomas are relatively easy to spot, though there are people that have what is called an occult primary melanoma, which means that it appears somewhere, like maybe in the retina of the eye. The primary tumor is in the retina of the eye and goes unnoticed until it's metastatic. Again, we can't really diagnose here, but what you should be able to do is recognize these three most common. Understand that melanoma and squamous cell carcinoma are pretty much are often sun related. People who tan, artificially. People spend a lot of time in the sun. That's because um, the inflammatory response to sun is to create more melanin. You're inducing the cells to grow and divide, which means that when you grow and divide, that means more risk of developing mutations that lead to tumors. And here you can just sort of see, here's a basal cell carcinoma, not particularly colored, just sort of uneven. You have some dysplasia. Dysplasia means that the tissue is no longer its normal characteristic. You can have hyperplasia, which is where there's more of the material. For instance, a callus is hyperplasia. Okay, but you can see that there's clearly some morphological changes. This is a dysplasia. And with squamous cell carcinoma, you begin to see this sort of redness and other things that'll bleed if you disrupt it, et cetera. That's because it's inducing blood vessels to grow into it. That's a term known as angiogenesis. And then melanomas right here, very dark, uneven. You can usually spot those pretty easily, and oftentimes people will notice that they're irregular, and or they can pop up fairly quickly and are pretty noticeable by their color change. Another pathophysiology aspect of skin is burns. And burns, the big issue is that you are disrupting the function of the skin, which means that you're prone for infection, prone for inflammation, and other things. So first degree burns, what we have is a superficial injury, superficial inflammation. Doesn't mean it doesn't hurt. It can be quite painful depending on where it is on the skin. Second degree, what you have going on is you have an inflammatory response to the point where you're starting to get blistering. This often means that you're getting down into the deeper layers of the skin. First degree usually just is epidermal only. When you start to get into the dermal layer, what you're doing is now you're inducing the blistering, much more severe, can lead to scarring in some cases. Third degree burn implies a complete abrogation of down into the layers, and now you're getting in below the skin layer, and now into subsequent tissue underneath, whether it's connective tissue or even muscle underneath. And this one is significant because you don't normally feel pain. You might feel pain on the periphery, where you don't have quite as severe a burn, like where maybe it's only second degree or first degree. That's where the pain's coming from. But in a third degree burn, you've destroyed the tissue to the point that you don't feel pain in those areas. When it comes to assessing how serious a burn is, wide-ranging burns, even wide-ranging first degree burns. Now, granted, we're talking about second and third here. Even first degree burns have some risks with them if they're over a large part of the body. We talk about the rule of nines. That is to say, the arms are worth 9, the head's worth 9, and then each leg is twice an arm, 18, and the torso is 18 on the front, 18 on the back. So it's a sort of rule of nines. When it comes to second and third degree burns, you are seriously abrogating barrier function of that tissue. And so there are significant risks, especially if you're talking about widespread burning. The first risk, again, the skin is fundamentally a barrier to infection and invasion by pathogens, or even commensal fauna, basic yeast or bacteria that live on our skin commensally. That is to say, they live sort of in harmony with our skin. Not necessarily harmony, but they aren't invading us actively. They're generally low-level populations on our skin all the time. And if we lose that barrier function, we lose the immune capability. And so infection and sepsis is one of the number one issues with burn risks, especially widespread burns where you're talking about more than 9 or 10% of the body. The infection becomes a very, very significant risk because you've basically stopped the infection barrier in its tracks by the burn. Fluid loss, dehydration. Again, the more widespread, the more the risk. Okay. Again, the skin is a barrier to prevent fluid loss, And so if you lose that barrier, you start to lose fluid unintentionally, which can lead to rapid fluid loss and dehydration. We call hypovolemia of the blood plasma. Systemic level inflammation. That is, if you think about COVID, when people were dying quite frequently in COVID, they were dying of what was known as a cytokine storm. Cytokines are the inflammatory mediators of cells. Every type of cell out there can secrete cytokines, which can then lead to pain, can lead to inflammation, swelling, and so forth and so forth. If you have enough of a widespread burn, rather than it being a localized phenomenon, let's say you burn your index finger. Well, you might see the finger swell up and you get a little inflammation there. What can happen with widespread burns is that you start to get systemic level. And that was the risk in COVID. You were getting a cytokine storm that was causing systemic level inflammation and organ failure. And the same thing can happen with widespread burns. You get an inflammatory syndrome that then causes multiple organ failure. Lastly, not least, but especially true when you're talking about widespread burns, you've lost the ability to regulate temperature properly, and so you can get a hypothermia syndrome. You don't even have to lose, you really don't have to lose that much temperature in your core before you begin to get before dysfunction occurs. So all of these things, infection, sepsis, inflammation, temperature, can all contribute to multi-organ failure in large burn patients. So how do we treat burns? Well, we're going to treat them in order to help support what would be the normal function of the tissue, keeping fluid inside the body. So we're going to give them fluids. All right. If one of the roles of skin is to prevent fluid loss, then we restore the fluids because we're losing fluids at an elevated rate. Nutrition. Now, this one may make just sort of common sense, but here's the actual rationale behind nutrition. When you injure tissue like skin, you're inducing cell division. And cell division is very caloric, but also requires a lot of proteins because you're literally building new cells. And in this case, these cells are full of protein. They're full of keratin. So that's why you need extra protein in there to serve as the building blocks for the proteins that you need to make in order to restore barrier function in the skin. Certainly, the skin is a barrier to infection. And so what are you going to do? You're going to augment the barrier by preventing bacterial infections, even relatively benign bacteria that normally just live on our skin any old day, or fungi in some cases. What you're going to do is you're going to try to sustain those populations at a level that is normal for a person so that you don't get an infection. Infection is fundamentally a numbers game. You have too many bacteria, you've got an infection, okay? Even if they're relatively benign and not super pathogenic. So what we're going to do is we're going to manage those bacterial populations and those fungal populations to prevent invasion. And then lastly, because of that thermal issue, we're going to keep these patients warm. Depending on how severe the burns are, we're going to have to do all of these things in order to keep this patient alive while attempting to regenerate the tissue barrier. And if it's a third-degree burn, they're definitely going to need, depending on how big it is. If it's small, you may get what you call secondary intention. You get where you'll get a scar that forms. There, if the tissue is, if the third degree is small, maybe it's a widespread second with a little bit of third, that the skin can sort of do it on its own. But if the third degree is wider than that and can't possibly regenerate even scar tissue, that's when you have to graft. Last few slides are just some supplemental, nice to know since you're moving into the clinic. We thought we'd include some of these slides for you. Now, I kind of like this slide because it shows the different types of receptors that we talked about earlier in the lecture. Meissner's, Merkel's, which are sort of free nerve endings, there's Pacinian corpuscles, and you can see the capsules here. I think that's kind of cool. These are more differentiated than the Merkel's. Merkel's sort of just a general free nerve ending. And so you have the different structures where they're sort of found in the skin layer, how big their fields are. You can see these ones are relatively small receptive fields, and then the more widespread ones. This down here at the bottom, I think, is the most interesting and one that I would encourage you to kind of get to know. And this is showing you two different kinds of phenomena that we see when it comes to sensory reception. Notice that you have these are action potentials, so we're seeing action potentials in the sensory neuron, and even though the stimulus is still present, we get a burst of them and then nothing. Whereas this one here, you get a burst of them, but then you're still getting a pattern there, but it's at a slower rate. Again, kind of a bursty little thing and then nothing. And maybe a little bit of a burst, but then it slows down, even though the stimulus is still present. So these two fast ones are known as phasic receptors. Your sense of smell, by the way, you might go into an anatomy class, where you're doing dissections, and you smell the formalin when you walk in, and it smells really strong, but by the time you're done, it's either you don't smell it at all, or it's a very, very weak sensation. Same thing when you're jumping into a swimming pool that's a little bit chilly. You jump in, it feels cold at first, but then after a minute or two, you kind of even out, and that's a phasic phenomenon. So even though the stimulus is still present, the perception of the stimulus diminishes or goes away entirely. Now, tonic phases, and that's what these two are, you're still seeing some action potential. You will still perceive it, but maybe not as intense as it was right there at the beginning. The receptors adapt, but they never completely adapt. Vision is a tonic receptor. So if you go outside, it's real bright, you don't go blind. Now, it might feel like you're blind for a minute or two if you come out of a dark room, but you can still see after 30 seconds or so. Same thing with your hearing. But sense of smell, if you ever go to a new person's house, at first you might notice a distinct odor in the house, but then if you spend more than 30 to 60 minutes there, you'll probably not smell it anymore, or minimal. Okay. And if you started living there, you might lose it altogether. Those are phasic. So phasic is where you can lose perception altogether. Like I remind you that you're wearing socks. Oh, yeah, I am wearing socks. You didn't feel it before. You might just barely tell. And then tonic receptors, you don't fully adapt. You adapt a little bit, but you don't ever completely shut off the perception. And you got some other receptors. So we were just talking about phasic receptors. Well, cold receptors and warm receptors. The thing about these guys is that they are two different populations. So, and they are sensitive to change. Okay, they are sensitive to change, not so much absolute temperature. There are hot receptors, especially inside your mouth, that not only are thermoreceptors, but they are also sensitive to a compound known as capsaicin, which is what we find in hot peppers. So even though your mouth feels like it's on fire, if you actually stuck a thermometer in there, you'd see that the temperature has not gone up at all. We've got touch and pressure receptors. I always think of Pacinian as pressure, P with a P. Meissner's, again, vibration, maybe some texture. Merkel's disc, those are sort of the free nerve endings. Pain and sort of non-indiscriminate touch. And talking about melanoma again, which is the most dangerous skin cancer out there, the one that leads to the most likelihood of mortality, especially if left untreated. So you have this A, B, C, D, E. So is it asymmetric? Like this one's symmetric here. That's much more normal. It may be a mole or something along those lines, but you can see this one's definitely asymmetric. See that here too. All these are kind of asymmetric. The border, nondescript, it's ruffled in some cases or uneven. This one's much more mole-like, much more specifically, one or the other. Color, you get uneven color. All right, so we have asymmetry, border, color. You can see the unevenness or the very, very dark color in some cases. Diameter, that's the D. Again, the larger, the more likely it is something that's needs to be treated. That's because these cells are dividing rapidly and they're spreading laterally. And lastly, evolving. That is to say, you begin to see clusters of dots, rather, where you're seeing multiple spots where you might have only had one or two before. Now you're getting a bunch of different ones. It's sort of related to border and asymmetry, only what's happening is they're just a little bit further apart. You're getting colonies of cancer cells that are just far enough apart that you can see material in between them. So asymmetry, border, color, diameter, and evolving. So that's it today for the integumentary system. I hope you've gotten something out of this lecture. Again, you're looking for, you don't have to memorize everything on every slide. Look to see where we're spending time on the slides, whether it's in this lecture or in our live lecture. I hope you will refer to this lecture if you're having trouble keeping up in person. Use your resources and understand that time is something that's going to be required, whether it's in class or not in class. Time is something that you want to use carefully, but time is something that you really can't skip when it comes to getting this stuff down. And again, the more you get this stuff down, the easier other material gets, and the more effectively you'll be in once you get into the clinic and you're working with a healthcare team and specialists. So good luck. Thanks for your time, and I will talk to you again soon.